Good afternoon, everybody. I'm Jianmin Liu from Changhai Hospital. It's my pleasure to present the result of DIRECT-MT trial on behalf of all the DIRECT-MT investigators. Our trial was funded by China Stroke Prevention Project and the WJP Medical Foundation without any funding from the industry. Endovascular thrombectomy preceded by intravenous alteplase has become the standard of care for patients with acute ischemic stroke due to large vessel occlusion in the anterior circulation since 2015 after the publication of 5 landmark trials. Risk and benefit of alteplase before thrombectomy are controversial. Treatment with alteplase may increase the likelihood of reperfusion, but it may increase hemorrhage risk, delay thrombectomy, increase risk of thrombus migration, avoid reactions, and increase costs. Therefore, randomized evaluation is required. We designed this DIRECT-MT trial in close collaboration with Mr. Clinical IV group. We used the proper design to determine non-inferiority of thrombectomy alone compared with combination therapy. The protocol was published in International Journal of Stroke. The primary outcome was shift in MIS score. We plan to randomize 636 patients for 8% power to establish non-inferiority with a lower boundary of adjusted come-out ratio of 0.8. Randomization was performed in a 1-to-1 ratio and stratified by site. We included adult acute ischemic stroke patients with an stroke score more than 2 and without aspects requirement, who were presented within 4.5 hours after stroke onset. Large vessel occlusion was confirmed by CTA, which included intracranial segment of M1 and proximal M2. Informed consent should be gained before randomization. Patients with pre-stroke disability and any contraindications for TPA according to AHA-ASA guideline were excluded. 41 sites in 18 provinces of China participated in this trial. All centers should be local academic tertiary hospital with efficient workflow and more than 30 cases of mechanical thrombectomy in previous year. In our trial, we used the standard dose of intravenous alteplase. Alteplase infusion could be completed during the endovascular thrombectomy. Standard retrieval was first-line strategy for the endovascular thrombectomy. Any FDA-approved device is allowed. Intra-arterial alteplase or urokinase could be used in both groups as a rescue therapy. We finished enrollment in 17 months, which is 3 months ahead of our schedule. We assessed 1,586 patients for eligible, randomized 656 patients finally. A total of 327 patients were assigned to thrombectomy alone group, and 329 were assigned to combination therapy group. 299 patients in the thrombectomy alone group, and 292 patients in the combination therapy group received thrombectomy. 1 patient in each group was lost follow-up. Baseline characteristics were well balanced between 2 groups. Only 8% of patients in thrombectomy alone group and 5.8% in the combination therapy group had intracranial atherosclerosis related large vessel occlusion, which is lower than those reported in previous study for Chinese population. Workflow time were comparable to those in Western countries. Median time from randomization to growing puncture were 31 minutes in the thrombectomy alone group and 36 minutes in the combination therapy group. It's only 5 minutes longer after using alteplase without statistical significance. However, median time from the randomization to revascularization was 6 minutes shorter in the combination therapy group. 35% of ICL occluding in our trial, which is relatively high as compared to previous similar studies. According to protocol, 87.2% of the patients in the thrombectomy alone group and 85.4% in the combination therapy group used stent retrieval as the first-line strategy. Successful reperfusion was defined as ETT score 2B, 2C, and 3. The percentage of patients with successful reperfusion before thrombectomy was 2.4% in the thrombectomy alone group and 7% in the combination therapy group. And the successful reperfusion on final angiography was observed in 79.4% and 84.5% respectively. The primary outcome was modified the ranking scale score at the primary analysis. The adjusted common odds ratio was 1.07. Thrombectomy alone was non-inferior to combination therapy because the lower boundary of the 95% was greater than the pre-specified value of 0.8. The p-value for non-inferiority is 0.04. Pre-specified subgroup analysis showed there was no heterogeneity for treatment effect by different subgroups. The safety outcomes were comparable between groups. The rate of death was similar of both asymptomatic and symptomatic intracranial hemorrhage were slightly higher in combination therapy group. However, there is no statistical significance. Rates of procedural complication were also similar in two groups, which is 15% and 14.3% respectively. The strengths of our trial included pragmatic trial design, good execution to high international standards, comparable workflow time to Western countries. Our trial also has limitations. It was designed using a relatively generous non-inferiority margin. According to 2015 HAAC guideline, new thrombectomy device and thrombolytic engines were not included. Meanwhile, we only included mothership patients. Therefore, the time allowed for acteplase to act before thrombectomy was short in this trial, which could also be seen as a strength of this study. To conclude, thrombectomy alone is non-inferior to combination therapy with alteplase in alteplase eligible patients due to anterior circulation large vessel occlusion within a relative margin of 20% based on a multi-center trial in China. This result needs confirmation from ongoing trial in other populations. This trial was published in the New England Journal of Medicine on May 6. I would like to take this opportunity to thank all patients and their families, all trial committees, all sites and core investigators, and all funding agencies. Thank you for your attention.